Hi, you guys, and welcome to the channel. My name is London. I am a labor and delivery nurse and have been for many years. I have assisted in over 100 deliveries and have helped women from lower economic status to higher economic status, women who have done C-sections, high birth deliveries, women who have gone unmedicated. So I have a realm of knowledge when it comes to labor and delivery, and also the postpartum phase and also the antepartum phase. And I am here to help you guys make informed decisions, and that is what this channel is for. It is to help educate you guys so that you feel empowered and inspired to make your own decisions when it comes to your healthcare, or partner with your healthcare professionals so that you guys can come up with a plan of care for you that best fits you. I am in no way giving any advice on this channel. I want you to really take the information, learn from the information, but really come up with a plan of care with your particular healthcare professional. So please understand that this channel is not giving any advice to anyone. It is simply my knowledge, what I have gained, and I am sharing that with you to hopefully educate you in some way so that you can make better decisions for yourself. So without further ado, today we are going to be talking about the induction process, and I am going to be breaking this video down into sections. If there is a particular section that you are interested in, please feel free to skip ahead and go to that particular section. I will leave all the timestamps down in the description below. However, I really do recommend that you watch the whole video because there are so many gems that are in this video. If you are someone who is either scheduled for an induction, or if your healthcare provider has told you that you will need an induction, I really recommend, listening to the whole video so that you can hopefully get some knowledge from this video and some gems, and write down some questions so that you can go back and have a conversation with your healthcare provider. So the timestamps are going to be, first thing we're going to talk about in this video is what to expect with an induction and who is someone who should be being induced. The indications for an induction. We're going to, talk about that. The next things that we are going to talk about is what medications you can expect in an induction and what those medications are used for. The next thing we're going to be talking about is cervical examinations and what to look for within your cervical examination. The next thing we're going to talk about is time frames, how long an induction takes to really set the expectation for you when you do go in to get induced. And then the last thing we're going to be talking about is I'm going to be giving you guys just a couple ideas of questions that I would ask my healthcare provider if I were going to be getting induced today. So let's get into it. Okay, so what are some indications for an induction? And indications just basically means what are some reasons people would be induced, right? What are some reasons that your healthcare provider may say, we need to schedule an induction for you because of XYZ? Typically, an induction is scheduled at about 39 weeks, but sometimes inductions are scheduled earlier depending on what is going on with you and also your baby. So reasons inductions, maybe your healthcare provider may say that you need an induction. Number one, and this is the most common one that I see, is preeclampsia. Preeclampsia is a condition that is associated with blood pressure, and the risk is eclampsia. So that is one of the reasons, which is basically seizures in pregnancy. So that is one of the reasons why your healthcare provider may say you need to be induced. The other reason is something that I see that is also common, which is IUGR. That is how they word it. It is intrauterine growth restriction. And that is when the baby's not growing to the size based on percentiles that your healthcare provider may feel that the baby should be growing at. And so they may recommend an induction. The next thing that I see is something called polyhydramnios and olyhydramnios. Polyhydramnios means that there is too much amniotic fluid, and olyhydramnios means that there is too little amniotic fluid. So healthcare providers may recommend inductions for those two reasons as well. The last two things that I really see when it comes to scheduled inductions is something called cholestasis. This is a condition where you may be very itchy, and it can get worse and worse throughout pregnancy. And then the last thing, which this really isn't the last things, there's multiple other things. These are just the most common reasons. But the last most common one that I see is something called gestational diabetes. This is, and you can either be diet controlled or you can be on insulin. If you have gestational diabetes, some healthcare providers will recommend scheduling an induction just so that the baby doesn't get too big. And there are several different reasons for that. I almost forgot one more, but the actual last one is also for post dates. That's when you have gone over 41 weeks of gestation and nothing's really happening. Your body's not really going into labor. And so your healthcare provider may recommend an induction in that case as well. If you guys want me to break down all of these different things and go further into detail as to what all of these different conditions mean and why an induction would be recommended, just let me know down in the comments below and I can go through each one and create a video about that. But just so that this video isn't too long, we're just going to name them. And if you want more detail as to what each condition means, how it affects the baby, how it can affect you, I can go into that. Just leave it down in the comments below so that I know you guys want to see a video about that. So back to the induction process. So when you go into the hospital for an induction, the first thing that we usually do is you usually skip the triage area unless for any reason you come in on a date that you're not scheduled to be induced. But if you have an appointment and a time to be induced, you usually go right into a room unless there is no rooms available. Your nurse will do all of your triage stuff inside of your room. You will get an IV, which is a line that's into your vein. This line is very important. It is the only really way we can help you or the baby. In the event that you need something, we can use that line. In the event that the baby needs something, we can also use that line. And what the baby will mostly need from that line would most likely be fluid. So an IV is usually placed at most hospitals, all hospitals that I've ever been at. An IV has been required for an induction because giving you fluid is one of the resuscitative measures that we do to help the baby in the event that the baby needs some help along the way during labor. The next thing that happens is you'll get a series of questions when you go in. Your nurse will ask you a series of questions. Your partner can be there. Usually they set you up and they talk about what medications you are going to be offered or how the induction process is going to work. And it's usually like, I would say 1 to 2 hours of not much happening, just them admitting you into the hospital. So once you are admitted, usually your healthcare provider will come in and they will talk about the various different medications that we give for an induction, and you also may get a cervical exam. So let's start with the medications that are offered for an induction. The first medication that is usually offered for an induction is a medication called misoprostol. We give this medication in very small doses. It's usually, you can give it in 2 ways, either vaginal or oral. Most healthcare providers will give it oral. I've seen very few who give it vaginal just because of the effectiveness of it when you give it vaginal. But you know, most healthcare providers give it oral just because the studies show that when you have it oral, it's a little bit more effective. So Misoprostol is a prostaglandin. It is a medication that is used to thin your cervix, and we're going to talk about what thinning your cervix means when we talk about cervical exams. So it is a medication that's used to thin your cervix. The next medication that may be offered at your particular hospital is a medication called Cervidil. Cervidil is another prostaglandin. This medication, it kind of looks like I don't know, like a small kite. It's like a paper. It looks like paper, and it has a string at the end. And Cervidil is placed vaginally. That is the only way that it can actually be placed. It's placed vaginally, and it is used to help ripen the cervix. So misoprostol and Cervidil are prostaglandins. Most hospitals have moved more towards misoprostol and using misoprostol more. There are several different reasons why your healthcare provider may want to use Cervidil, but I am seeing that Cervidil is being less and less used in the hospitals today. So, but that still is an option in the event that your healthcare provider thought that it would be necessary. Instead of using misoprostol, they would use Cervidil. And misoprostol, let's go back to misoprostol. Like I said, it is a prostaglandin. You can get up to 6 pills of misoprostol usually in most hospitals. And it is given every 4 hours, as opposed to Cervidil. It stays in for about 12 hours. And unless your healthcare provider pulls it out before then, or unless you become more active. And that's with either of these medications. They're not going to be given to you if you're starting to become more active or if your cervix is changing and you no longer need them. The next thing that is used to help with an induction is a cervical ripening balloon. Okay. This is a mechanical dilator, and most doctors say that it does both things. They say that it softens the cervix, and they also say that it mechanically dilates you. In my personal opinion, I feel like it mostly just mechanically dilates you as opposed to softens you, which is more of what misoprostol would do, or Cervidil, soften your cervix. Those are prostaglandins. The cervical ripening balloon really just mechanically dilates you. And that balloon can stay in to up to 12 hours. And usually it falls out before 12 hours. And when it does fall out, you are anywhere between 3 and 4 centimeters, most likely. That can vary for different people. Usually if it hasn't fallen out and I'm taking it out of my patient may just be 2 centimeters, barely 3 centimeters, or like 2.5 centimeters. But mostly when it falls out, if it was placed correctly, you should be at least 3 centimeters dilated. The next medication, and this medication has such a reputation. Every time my patients come in, they're like, I gotta get Pitocin. And Pitocin is pretty much the last line of medication that we use in an induction process. It is a medication. I say that it is the force. It is artificial oxytocin. So just a little backstory, we release oxytocin all on our own. And the artificial oxytocin helps in conjunction with our own oxytocin. So that is really what Pitocin does. It helps to make your contractions more regular, and it helps to make them stronger. There's various different levels of Pitocin. There's high dose Pitocin and there's low dose Pitocin. Usually we start off with a very low dose Pitocin to see how you and your baby are tolerating Pitocin. And it is a medication that is very titratable. So in the event you or your baby is not really tolerating the Pitocin, it is always able to be turned off. You can just ask for it to be turned off, especially if you're in a lot of pain and you're in the process of getting your epidural and you don't feel like you could sit still, things like that. You could ask for your Pitocin to be turned off until you get more comfortable. In the event that your baby's not tolerating the Pitocin, most likely 9 times out of 10, your healthcare providers, you will hear them saying, we turned off your Pitocin, we turned off your Pitocin. So that we can calm your uterus so that also the baby can recover if anything's going on with the baby. But it is a titratable drug. It is not something that we push. It is titratable. I usually say that Pitocin should be the last line of medication used, because sometimes what I see in inductions is some of my patients don't even need Pitocin. They do really well off of a couple misoprostals, or they do really well off of misoprostol and a cervical ripening balloon, and they usually may not even need Pitocin. There are some patients who need it all, and they still do very well. I just don't want you guys to go in and be scared of Pitocin, because I have seen all of the horror stories online about what people feel like Pitocin is responsible for. But there are various different reasons why some of these things could have happened. And the misconception sometimes I feel like is that Pitocin is the cause. But there's various different reasons, and I just want you to understand that Pitocin is a titratable drug. You can always ask your healthcare provider, if you are on Pitocin, to start off with low dose Pitocin. You can ask them for several different things within that. I don't want you to feel like just because you're on Pitocin you can't ask for things. You definitely can, depending on your situation, depending on what's going on with you and your baby. You can come up with a plan with your healthcare provider and let them know kind of what you're thinking and what you're feeling in regards to Pitocin. So that is really the induction medications that are used to induce labor. That's when you don't come in with any type of labor. You're not really in any labor. Those are the medications that they may use to induce you. During the induction process, there's also one other thing that they may do to continue to push your labor in the right direction, or like another natural induction agent, if you want to say. And I really say natural in parentheses because it's not really natural. We're doing it to you in the hospital. We're doing something to you. So anytime we're doing something to you, it's not natural, but it's like a least invasive method is breaking your water, and we call it rupturing your water bag or breaking your water. That is also something that may happen later on down the line in your induction process if we kind of feel like you've stalled out, or you're making good change, or you just need a little push. Your healthcare provider may say, hey, let's break your water. Give the baby a chance to come down, or give, all that. I think that's all you need is maybe your water to break. And that's going to help send some signals to your brain to help your uterus contract a little bit more. So that may be something that they say throughout your induction process or during your induction process is, hey, let's break your water. So if that is, don't be alarmed. We're also going to go over some things that I want you to pay attention to when you are asked that. So now on to the next thing, which is cervical exams. So during the induction process, you will get a cervical exam. Cervical exams are not comfortable. If you've ever had a cervical exam, you definitely already know that they are not the most fun thing, and they are not comfortable. So just be prepared for that. And there is multiple cervical exams within an induction process, because since we're putting you into labor, we have to make sure that what we're doing is working, because the whole point and reason why you're there is because we want to get you delivered. So cervical exams are usually performed. Now, I want you to pay very close attention to this part. There are things that you need to pay attention to when it comes to a cervical exam, okay? The first thing that you need to pay attention to is, of course, your dilation. This is what most people pay attention to, and they tune everything else after dilation out. And I do not want you to do that. I want you to pay attention to not only your dilation, but the next part of your cervical exam, which is your effacement, okay? Especially in that latent stage of labor, which is an early stage of labor, which is the longest part of labor. You want to pay attention to what your effacement is. And what effacement basically means is how thin is your cervix? How thin is it? Is it 10%? Is it 20%? Is it 30%? Is it 40%? Is it 50%? The effacement can go anywhere from 0 all the way up to 100%. If you're 0, we don't really even give you an effacement. We just say close, thick, and high. That's an exam that somebody may tell you if we don't even know what your effacement is. It's so thick. They may just say close, thick, and high. But if you are effaced, they may say you're 1.5 centimeters, 50% effaced, and -3. Okay, we'll talk about the -3 in just a second. But what I do want you to understand is the effacement is very important. Okay, the effacement is the thinning of your cervix. And in the beginning of labor, that is really what your body is trying to do. It is trying to get your cervix thin. When you come in for an induction, that should really be the goal, is try to get your cervix thin. Because when a cervix is very thin and it's nice and it's thin and it's ready for labor is what I call it, then it will dilate beautifully. But if a cervix is very thick, and thick, usually if you're 50%, 40%, 30%, 20%, you're thick. If you're moving over the 50% hump, you're 60, you're 70, you're like not super thick, but you're like medium, okay? But you're not thin yet. When you're 80% and you're 90%, oh, you're ripening beautifully. Just think of like a flower opening. Your flower is just like opening very beautiful. When you're in that sweet spot, when you're moving past 70%, you're moving. The thinness is very important. The thinner you are usually helps aid in your dilation. The thicker your cervix is, usually it's a slower process for you to dilate, if that makes sense. So you want to pay attention to your effacement, pay attention to it, pay attention to it. The next part of your cervical dilation is going to be your station, okay? Your station is where the baby is in comparison to your pelvis. And your pelvis is 0 station, okay? Where your pelvis is, that's what we call 0 station. Anything above 0 is negative. So there's -1, -2, -3, okay? If your baby is -3, your baby is high. That is what we call high. -2, your baby's coming down. -1, your baby's almost at the pelvis. Okay? +1, that means your baby's below that pelvic inlet, which is really good. Usually when you're about +1, you're getting very close to being complete. That's usually when we see you being +1. You're either complete or you're ready to push. Around that time, that's a really good time for you to start pushing and start moving that baby so you can deliver. But usually anything above, when you're coming in for a dilation and you're not in any type of labor, most people are anywhere from super high, we just say high, or you're -3 or you're -2. Most people don't come in at -1, but there are some who do. But most people are -3, -2. So if that is your station when you go in for an induction, that is not abnormal. So now on to time frame. And I really want to set the expectation when it comes to how long an induction can take. When we are putting your body into labor, we are doing something to you to make you go into labor. You didn't come into labor. And so I always say, if you are scheduling an elective induction, please consult with your healthcare provider about the risk, because the best way to come into a hospital is come into the hospital in labor. Now, if there's medical reasons in which you need an induction, then of course you need to come in, you need to be induced because of these different medical reasons, because the risk of the medical reasons outweigh you waiting until whenever you would go into labor. But if you don't have any medical reasons and there's no particular reason why you need to be induced, except for you want to have a baby on a particular day, you want to have the baby before your parents leave, you want to have the baby because you're tired of being pregnant, you want to have the baby because you just want your body back, you want to have the baby because you haven't had sleep in 5 months. I get it, mamas. I get that you are over the pregnancy. I get that you want to be done. I want that for you as well. However, the best way to come into a hospital is when your body is already going into labor. And I can create a video on how to actually get labor kickstarted, when to start doing these things to kickstart labor. If that is something that you want to see, also leave it in the comments below. But really, honestly and truly, it is best to come into the hospital with your body, your brain realizing, hey, it's time to have a baby, because then things go, things move. When you are being induced, it is a much slower process. There are some people who come in, they get induced and they move super quick. But most people who come in and they get induced, it is a slower process. And I would say it could take anywhere between 1 to 2 days, which is 24 to 96 hours, being in the hospital, not even delivered yet, but just kind of trying to become delivered. Usually by the 4th day, if you haven't delivered, your provider is going to probably talk to you about a C-section, because at that point, they're going to deem you as a failed induction, unfortunately. Because if at that point, at the 4th day, they've done everything. Your water is probably broken. You've probably gotten all the things. If your cervix is stalling out, they're probably going to deem you as a failed induction. So it usually takes about that time frame. There's only one case in all of my years that I have seen that has made it past 4 days. And so it's not a very likely thing, just because there's several different risks that starts to come with prolonging labor for that time frame. But yes, so that is the time frame when it comes to an induction. The next thing that I really want to talk to you guys about is what kinds of questions you should be asking your healthcare provider if you are someone who is going to be induced, or if you are thinking of an induction. Like I said, the best way to come into a hospital is to come into the hospital already in labor, whether it's early labor or active labor. That is the best way to come in to deliver your baby. However, if you are going to be scheduled for an induction, the things that I would ask, the number one question I would ask is, why am I being induced? Why am I being induced? Am I being induced just because you want to deliver me before you go on vacation? What is the reason for me being induced? And is this reason a medical indication for me to be induced? That is the first question that I would ask. It's a loaded question. So that's the first question I would ask if I were going to be induced. Again, these are things that I would do. I am in no way trying to tell you that this is what you should do. But if I were pregnant today and I were going to be induced, the first question that I would ask my healthcare provider is, why am I being induced? And is there a medical reason for me to be induced? The next question that I would ask my healthcare provider is, what medication do you plan on starting me with the induction process? And will, someone check my cervix prior to giving me that induction agent? It's important to check your cervix beforehand because you really want to know where you are. Where is your cervix? Is it soft? Is it not? Is it closed? Like where are you, And then I would ask, based on my cervical exam, will you be giving me something to help my cervix thin out? So if I'm closed, if I'm 1 and I'm thick, if I am 2 centimeters, but my cervix is still very thick, will you be giving me something that can really help thin my cervix before something, let's say like a cervical ripening balloon or Pitocin? What is your process when it comes to medications? Like, do you start with prostaglandins, which prostaglandins are the medications we talked about, misoprostol and Cervidil. Those are the medications that help thin your cervix. And that is really what we want to do in the beginning of an induction. We want to thin your cervix because that is what early labor does. It's responsible for thinning your cervix so that it can dilate beautifully. And you also do dilate in early labor. You have to get from 0 to 5 centimeters. That is considered early labor. But in order to do that, you need to be very nice and thin. So that is one of the things that I would ask about. Are you going to be giving me medications that is going to help thin my cervix based on my cervical dilation, especially if I'm anywhere between 0 and 2 centimeters? The next thing, and it is my first baby. That's also something that's very important to note. Second-time mamas and first-time mamas are very, very different. This video in particular is more geared to first-time mamas because second-time mamas, it's different. Your cervix is very different than a first-time mama cervix. You know that the time it takes to deliver is very different as well. And we can go into the differences between first pregnancies and second pregnancies and what are those differences that you may experience. Again, leave it in the comments below if that's something that you want to see. Then the next thing that I would be asking is, what is their C-section rate? You do want to know what their C-section rate is, particularly your provider. It's a good question to ask. What is their tolerance when it comes to labor? What is their C-section rate? What is the hospital C-section rate? And what is their personal rate? Because doctors get their own personal rate and hospitals also get their own rate. And it is not an abnormal question to ask. It is actually a conversation that I think should be had prior to the bedside so that you can have a conversation under very calm circumstances. In the event of a C-section, what does that look like for me? What is the process that you go through? What kind of incisions do you do? All of those different things. Those are other questions that I would ask when it comes to your healthcare provider if I were being induced. Oh, I almost forgot. There's one more question that I would ask. Actually, it's kind of like a twofer. I would also ask whatever medication we're going to start me on with my induction, is there a way that I can be on intermittent monitoring so that I can move around? And also, will I be able to eat? That is another question that I would ask if I were going to be induced today. So that is all of my questions. I really hope that you guys learned something from this video. I know that it was a lot of information, and if this is all foreign to you, it can be very confusing. If you do have questions, please leave it down in the comments below. I hope that I can help you with any of the questions that you have, but definitely subscribe. I have created this channel to really bridge the gap between patients being misinformed and patients who are informed incorrectly and, you know, make decisions based on incorrect information. I'm really trying to bridge that gap and help mamas and patients to understand that the healthcare system is there to help you when you need it, but also your body does amazing things. And if you have the education, then you'll be able to advocate for yourself within the healthcare system so that you don't feel intimidated, so that you don't feel overwhelmed, and so that you don't feel like you have to refuse everything because you just don't know. I'm really trying to bridge that gap so you can make informed decisions, you can make educated decisions, and you can really do what is the best thing for you and your baby and your family. So if that is something that you are interested in, definitely do not forget to subscribe and also like this video so that it goes out to more mamas, because I'm telling you, there's so many gems in this video that I really want so many women, especially first-time mamas who have never experienced pregnancy and labor, to know prior to going into the hospital. So until next time, I will see you guys in my next video. And yeah, love you, wishing you the best, the most safe, and the most wonderful delivery. Understand that this is a journey and just enjoy the journey. Bye.